Good afternoon, I'm Laura Chatterton performing a neurological assessment on my patient Martin. To begin, I'm going to examine the patient's general mental status. I'm going to be observing their appearance and their behavior, looking at their use of speech and language, determining their mood, looking at their thoughts and their perceptions, examining their orientation, their attention, and recent and remote memories will fall under that guise. Having determined the patient is normal, I'm going to next proceed to an examination of cranial nerves 1 through 12. These emerge from the cranial vault through the skull foramen and canals to structures in the head and neck. Cranial nerve number 1 is the olfactory or sense of smell nerve. It is a sensory nerve. It is located within the nose, and in order to test, I'm going to ask the patient to occlude one side of their nose and breathe through the other. And then again. Once we've tested for patency, I'm going to ask the patient to close their eyes and identify each smell. Because the patient is able to correctly identify the smells, we say that they have an intact cranial nerve number 1. Cranial nerve number 2 is the optic nerve. It is a sensory nerve as well. It's located in and behind the eye. It controls central and peripheral vision. It is tested through tests of visual acuity, which involve the use of a Snellen chart, and through visual fields by confrontation, which is the static finger wiggle test. These have already been done in a previous video, so we are going to omit those for today. Next, we move on to an examination of cranial nerve number 3, the oculomotor one, the cranial nerve number 4, the trochlear, and cranial nerve number 6, the abducens. Cranial nerve number 3 and number 2 combine for pupillary response. We test the patient's pupils for size, shape, and symmetry and movement. A pupil greater than 5 millimeters is considered large, less than 3 millimeters is considered small. The normal shape should be round, and the pupillary response should be a 4+ or brisk when light is introduced. We can also test by direct reaction and consensual reaction. And these 3 nerves combine to not only create the pupillary reaction, but also accommodation and convergence, as well as extraocular movement, all of which have been previously tested. Cranial nerves 3, 4, and 6 are motor nerves. Cranial nerve number 5 is the trigeminal. It is a mixed nerve. It has both a motor and sensory component. From a motor perspective, we're going to have the patient clench their jaw. We're going to palpate for the temporal and the masseter muscles for strength of contraction. We're going to ask the patient to open his mouth, moving his jaw side to side. Then we're going to test for the sensory component where the patient will close their eyes and identify either a dull or sharp sensation.
Sure.
Notice that we test the forehead, the maxillary, mandible areas, as these are where the trigeminal nerves innervate. We also want to test the corneal reflex. With a wisp of cotton, we ask the patient to look up and over to the side. We wisp the cornea with a little bit of cotton. When the patient's eyes constrict or close, we know that that is a combination of the sensory aspect from the trigeminal nerve as well as a motor response from cranial nerve number 7. This patient has appeared and has responded appropriately. Cranial nerve number 7 is the facial nerve. It too is a mixed nerve. It covers most of the face. We look for any asymmetries in the nasolabial folds. We also look for any abnormal tics, movements, or fasciculation. We're going to ask the patient to raise their eyebrows, then to frown, resist when I try to open the eyes. I'm going to have the patient smile, showing both sets of teeth. I'm going to have the patient puff their cheeks out, and then give me a really good smile. From a sensory perspective, we would test it by putting something like sugar on the anterior 2/3 of the tongue for taste. Cranial nerve 8 is the acoustic and vestibular nerve. It is a sensory nerve that deals with hearing. To test it, we would perform the whisper voice test, the Rene test, and the Weber test. All of these have likewise been performed in previous evaluations and will be deferred. We'll next move to cranial nerve 9 and 10, the glossopharyngeal and vagus nerves. These are a mixed nerve as well. We're going to look for voice qualities, noting hoarseness or nasal sounds when the patient speaks. We would perform a gag reflex test that we will defer for today as it can elicit a vomit response, but we would stimulate the back of the throat to initiate the gag reflex. We're going to ask the patient next to say, ah, and we're going to look at the structures inside the mouth. We're going to be looking for the soft palate to rise symmetrically, for the uvula to be midline, and for the posterior pharynx to move medially. We're also going to check the patient's swallow reflex by watching the movement of cartilage in the neck as the patient swallows. Next, cranial nerve number 11, the spinal accessory. It is a motor neuron that innervates the shoulder and neck areas and is responsible for movement. We check first the trapezius muscles, comparing side to side, looking for any atrophy or fasciculations. We are also next going to ask the patient to resist as they shrug their shoulders. This tests the strength of the trapezius muscles, and then we're going to test the strength of the sternocleidoid mastoid muscles by having the patient press against each side of my hand. After that, we move on to cranial nerve number 12, the hypoglossal, which is a motor nerve. It innervates the tongue. We check by looking at the tongue on the floor of the mouth, then asking the patient to stick the tongue out, looking for any atrophy, asymmetries, or deviations, and then we ask the patient to move their tongue side to side, making sure that that nerve is intact. Our next part of the exam will go to muscle strength, which we test through active through active resistance, grades 0 through 5. A 5 is a normal where there's active movement against gravity and full resistance without evident fatigue. As you go down each grade, the movement becomes less and less until you reach 0 where there's virtually no muscle contraction. Testing of the biceps, I'm going to have the patient make a fist and hold their arms up, and they're going to resist me. This is testing the bicep muscles. I'm also going to have the patient press against my hand here, testing the brachioradialis muscles. Please resist. And then I'm also going to have the patient turn their hand upright and resist. That actually tests the bicep brachius muscle. Testing the tricep muscles, I'm going to have the patient, again, just bend their arms and push out, noticing the contraction of the triceps. With bicep muscle testing, we're looking for the nerves that innervate from C5 and C6. With the triceps, the nerves come through C6, C7, and C8. It's the biceps, the bicep brachii, and the brachioradialis muscles with the flexion movements of the biceps. And the triceps, it's the tricep brachii with extension. Next, we're going to go to deltoids, holding the arm parallel to the shoulder. I'm going to move the arm back a little bit, have the patient push forward. That does the anterior component. The medial aspect, I'm going to ask the patient to push up against my hands. And from a posterior, I'm going to ask the patient to push back. Very good. Wrists, I'm going to have the patient hold their clenched fists out. The wrists innervate from C6, C7, and C8, the radial nerve, as well as the extensor carpi radialis longus and brevis. I'm going to have them resist my push, keeping the wrists firm. Flip the hands over with the palms open and resist. Fingers with abduction, we're going to be innervating through C8, T1, and using the ulnar nerves. We're going to hold the hands out with the fingers outstretched with resistance noted as I test each finger, both bilaterally. Next is adduction. I'm going to have the patient keep their fingers together. I'm going to slide a piece of paper in. They're going to resist as I pull out. We're going to do this bilaterally through each of the fingers to test for adduction. Adduction is purely ulnar nerve, whereas abduction is C8, T1, and the ulnar nerve. Next is the vastus complex of muscles which make up the quadriceps. I'm going to place my hand above the patient's ankle, and I'm going to feel as they resist with good contraction against my hand down by the ankle. We can feel all 4 muscle groups contract here. The gastrocnemius and soleus is an S1 innervation. I'm going to have the patient put their leg up, and then they're going to push against my hand, and I'm going to feel for the contracture bilaterally of those 2 muscles. At the end of this muscle strength testing, I'm going to move on to coordination, starting with the rapid alternating movements of the arms and hands, going back and forth as quick as possible. I'm looking for speed, rhythm, smoothness, and accuracy. With the legs, I'm going to have the patient tap against either the floor or my hand as fast as they can bilaterally, noting that hands move faster than the feet. Next, point-to-point measurement. I'm going to be testing for eye, hand, and foot coordination bilaterally. I'm going to be looking for accuracy and smoothness as the patient goes from their nose to my finger. Next, I'm going to have the patient place their heel over their shin and skim down all the way through the big toe. This is a test for smoothness and accuracy of their abilities to do so. I'm going to have the patient do it with their eyes closed, which is a test for position sense. Next, we're going to do gait and balance. I'm going to ask the patient to get up and walk across the room. I'm going to observe for posture, for balance, for swing of arms, movement of legs. When they turn around heel to toe for tandem walking, which is also a measure of balance, walk on the toes, walk on the heels, hop on each foot, and lastly, take some very shallow, deep knee bends. Very good. When this is done, I'm going to ask the patient to stand, and we're going to perform the Romberg test. I'm going to stand next to them just for safety. I'm going to have them put their feet together and close their eyes. I'm going to look for any abnormal swaying. A little sway is fine. Anything more than that is too much. This helps, again, with position sense. Next, we're going to do pronator drift. I'm going to have the patient put their hands outright with their palms up. And I'm going to have them close their eyes. They're going to stand there for somewhere around 30 seconds, and I'm going to look for drifting or for turning of the thumb towards the medial aspect. None of that is noted. Next, I'm going to tap and watch how the patient's arms rebound to normal position. There is no pronator drift with this individual patient. Next, I'm going to have the patient sit down. We're going to test for reflexes, knowing, too, that these are graded, 0 to 4, 0 is absent. 1 is somewhat diminished, but low normal. 2 is considered a normal finding. 3 is brisker than average, which could present a problem. 4 is very brisk, could be hyperactive with clonus. To test the biceps, I'm going to use the pointed aspect of my hammer, palpating the bicep tendon. I'm going to be looking for contraction of the bicep and a flexion at the elbow. Placing the finger in the area over the tendon, I strike, and you can note the movement. Next, I'm going to do the triceps with the arm stretched. I'm going to feel for the tricep tendon, and I'm going to strike it with a pointed end, looking for extension of the arm and tricep contraction. Brachioradialis is next, but using the flat side of the hammer 1 to 2 inches above the radiostyloid process while the patient rests their arm. I'm going to be striking that area, looking for the palm to somewhat turn out and some flexion in the forearm. Next is patellar reflex. Again, all of these are formed bilaterally. I'm going to ask the patient to just dangle their leg and relax. I'm going to strike the patellar tendon just underneath the patella, noticing a little extension of the leg. Achilles reflex is next, again using the flat side of the hammer, holding the leg up and holding the foot. I'm going to strike at the Achilles tendon. I'm looking for a plantar reflex where the toes will curve down. I also want to note the speed of relaxation after contraction. Next, we're going to do the Babinski reflex. I'm going to hold the patient's foot up in my hand. I'm going to rub an object, in this case a key, the lateral aspect from the heel all the way to the ball of the foot and then medial across. And I'm going to look for the patient to have a plantar reflex, which is considered normal in an adult. So we should see the patient's foot curve down. If the patient was to curve in a dorsiflex, that would be an abnormal finding. Children, typically up until the age of 1 or 2, will have a Babinski reflex, which is perfectly normal. In an adult, if they have a Babinski reflex, it's considered abnormal. Next, we're going to go to 2-point discrimination. I'm going to use the 2 ends of an open paper clip, and I'm going to ask the patient to tell me if there's 1 or 2 prongs that they feel. I'm going to do this across the palms as well as the finger pads. I'm going to be alternating between 1 and 2. Should be pain-free. I'm going to find the minimal distance at which the patient can discriminate from 1 to 2 points. It's approximately 5 millimeters on the finger pads, and I'm going to do it on all fingers and palms, both sides. Next, we're going to do the vibratory sense using my tuning fork. I'm going to strike it and place it on the interpharyngeal joint, asking the patient what they feel. Tell me when it stops. Okay. Then I'm going to do it again on the big toe. What do you feel?
Vibration.
Tell me when it stops.
Stop.
If for any reason the patient was unable to sense that, I would simply move proximal from that point to the next bony prominence and test it. Normally, both the patient and examiner will no longer feel the vibration at the same time, or will feel it end at the same time. Next, we're going to test proprioception, which is joint position sense. I'm going to grab the patient's big toe with my index and thumb. With the eyes closed, I'm going to move it up and down and have the patient tell me which way I'm moving it. Which way am I moving that?
Up and down.
I'm going to do this to the fingers as well, and if there's any impairment, I would simply move proximal. Next, we're going to test for stereogenesis, which is the ability to ID an object by feel. I'm going to place a familiar object in the patient's hand with their eyes closed and ask them to tell me what it is.
Key.
Normally, this happens within 5 seconds, and if I wanted to really test for sensitivity, I could give a coin and have them tell between heads and tails. Next, I'm going to do graphicsenisa, which is only if the other tests fail. With a blunt end of a pen or any other object, I'm going to draw a large number or letter
B.
in the patient's palm and ask them to identify what it is. Next, I'm going to do Kernig's sign. I'm going to have the patient lie flat down. This is a test if I suspect meningeal inflammation due to meningitis or subarachnoid hemorrhage. I'm going to have the patient flex their legs at the hips and at the knees, and then I'm going to straighten the knee out. Normally, there might be some discomfort. If there were meningeal inflammation, they would have an abnormal amount of pain and increased resistance. Lastly, I'm going to do the Brudzinski sign. I'm going to move the patient's head up, looking for movement of the hip and knee. If there is no flexion and those joints remain relaxed and motionless, that's a normal finding. Abnormally, both the hips and knees would reflex, indicating a potential meningeal infection. That concludes the neurological assessment. Have a good afternoon.